Top Med Talk.
Hello and welcome to Top Med Talk. I'm Kate Leslie and I'm here with my co-host Mike Grocott at the combined meeting of the International Anesthesia Research Society and Society of Critical Care Anesthesiologists in Honolulu, Hawaii. We've had a wonderful meeting so far, great plenary sessions, a wonderful clinical trials workshop, and best of all, fantastic poster research sessions with all this fantastic new research. How's your meeting going, Mike?
It's going very well, but I've only been here for about a quarter of an hour because I arrived a couple of days late. I had planned to arrive a couple of days ago, and the fire in the substation at Heathrow, which closed the airport, meant that I visited several cities I hadn't planned to visit and went on a lot of long plane journeys I hadn't planned to go on. So it's great to be here, but I apologise to the IARS that I managed to miss my own presentation. I'm very grateful to Dr. Sandy Jackson for covering for me.
Fantastic. Well, it's great to have you here. And just in time to interview our wonderful guest, Dan Cole.
I'm here today on behalf of the Anesthesia Patient Safety Foundation. I'm the president of the APSF, as it's known. I am a practicing anesthesiologist at the UCLA with a subspecialty in neuroanesthesiology.
And what have you been up to at the meeting?
A lot of really outstanding presentations. I've attended more scientific presentations in regards to research, and the quality has been sky high. What has really impressed me is the number of medical students and residents that have made phenomenal presentations. The future is bright.
It is indeed. And Mike, the APSF had the most viewed paper in anesthesia and analgesia last year.
Wow, didn't know that. Is it a consensus paper?
Yeah, it was a consensus manuscript based upon a meeting that we held in November of 2022 on perioperative hypotension and the risks associated with that. It was invited authorities on it, people from industry and from other national organizations and regulatory bodies.
And what was the process by which you came to the conclusions that are in the paper?
We had a Delphi method of putting together questions that we asked. We gave people homework ahead of time, refined those questions, and then when we came together for about a day and a half, we had short talks followed by breakout groups, which further refined some of the answers and recommendations.
And what were the sort of highlights from your perspective of the paper?
Well, this was published last year in Anesthesia Analgesia. We had 17 recommendations. Probably some of the top ones that we came out with was that perioperative hypotension is common. It is associated with significant morbidity with patients, mainly kidney, cardiac, and maybe brain injury. There are some gaps in how we monitor for perioperative hypotension and how we treat that.
You're also talking about the gap in patient communication, I believe.
That's a problem because the frequency with which intraoperative hypotension occurs, even with a very short period of time, is quite high. And so if you were to communicate that with patients, which they deserve to know, you want to communicate it in a manner that doesn't frighten them away from needed procedures and surgeries. Goal should be to involve the patient in their own care. Let them know of the risks of the procedure, what you are going to do to mitigate those risks, and actually treat it when it occurs.
I think in my practice, I often warn elderly patients that one of the main complications, along with pain, nausea and vomiting, might be hypotension during and after the case in the PACU. Well, I have to admit, I don't usually close the loop and tell them that happened and advise them to get any follow-up. Is that what the paper recommend?
I think the paper does make that recommendation. Probably the bigger question, though, is what happens when they leave the PACU and go to the floor. So intraoperatively and in the PACU, they've had very close monitoring where you can detect hypotension. That is a precursor to something more serious. When they go to the floor, they may have vital signs taken every 6 hours, and you may miss detection of early hypotension, which is again a harbinger of the deteriorating patient. And so that's probably, to me, the biggest takeaway from this conference.
The whole issue of informing patients, which relates to all of these different elements that we talked about at the meeting, but the challenge that there are some very informed patients around, but they tend to be informed about chronic illnesses, and we have a very episodic encounter with patients. So it's quite difficult to inform them at a level where they can make properly informed decisions about some of these issues like hypertension. I agree with you. I'm a great advocate for informing them that we somehow need to do that ahead of time and give them the space to think these things through. I don't imagine that they're anticipating these problems. We're suddenly presenting them with a whole load of new bad things that they didn't know were going to happen.
Yeah, and that's a great point. I do think the ideal state would be informing them preoperatively, possibly doing some things to mitigate their risk of perioperative hypotension. Then it would be a system information disclosure about the risks of hypotension during anesthesia, in the PACU, on the floor, in the ICU. So, intraoperatively, we're one silo, an important silo. But again, the ideal state would be to really let patients know that this is a real risk. And obviously, the future with the demographics of the patient population, it just gets higher and higher.
Yeah, absolutely. The numbers look very scary if you map forward age and procedure rates and some of the comorbidities, particularly obesity, that are accelerating at the moment.
Correct.
So for our listeners who are new to the field of the risks of perioperative hypotension, can you tell us which outcomes your working group considered to be most important and the ones our listeners should be looking out for?
This was a database conference in which we looked at all the data, and the outcomes for which there is strong associative data would be with a kidney injury, myocardial injury, and possibly a brain injury. Those are the outcomes, I think, that are most important.
And preoperatively, are there any ways that we can identify patients who are particularly at risk? Did that come out in your data analysis as well?
We didn't make any specific recommendations there, but obviously there are risk patients with multiple comorbidities, patients with a history of hypertension, especially if it's not very well controlled, patients with obesity.
Is that right? Is obesity a risk of perioperative hypotension?
Yes, it is.
That's interesting. I wasn't aware of that because many of those patients are suffering with hypertension preoperatively.
That's correct. But obviously obesity leads to a lot of other comorbidities.
We've got the comorbidities that drive the hypotension itself, which you've mentioned, but also the comorbidities of vulnerability. If you've got chronic renal impairment, even if very mild, your kidneys are probably more likely to be vulnerable to further renal damage, the same for the heart as well.
That would be a very reasonable assumption.
Certainly data to support that on the kidney side, and I guess we are pretty comfortable with the various cardiac morbidities, particularly ischemic heart disease, being a significant risk factor for subsequent ischemic injury.
Correct.
Did the group make any recommendations about withholding or continuing ACE inhibitors and ARBs?
We did not make that recommendation. I think that's an area of controversy.
It certainly is.
Yeah.
In the POISE 3 study, the continuation of ACEs and ARBs was associated with more intraoperative hypotension, but not postoperative hypotension. And intraoperative hypotension, as you know, is easily treated by anesthesiologists and not so much the case on the floor. The guideline you wrote had some interesting recommendations for the administration of peripheral norepinephrine, or noradrenaline as we call it in the old world. What would you like to say further about that? That's controversial as well.
To take one physiological variable in a treatment pharmacologically might convey a wrong message. When you see intraoperative or perioperative hypotension, instead of treating a number, you need to determine why that number is low. And far too often, I see people reflexively giving a alpha agonist like phenylephrine or norepinephrine to simply get that number up. If the patient were volume depleted or had some cardiac issue, that actually might produce harm. The important thing is you may need to transiently fix that number, but you should be searching for what the underlying cause is. And oftentimes, if the systemic vascular resistance is high, maybe you should be giving some volume because that patient is hypovolemic and not necessarily treating it with a vasopressor. So the important thing is to get away from treating a number and treat the underlying cause.
Completely support that. I wonder if inadvertently over the last decade, maybe a little bit longer, the combination of our focus on blood pressure, an important variable to target, and the sort of undercurrents coming from the IARS literature have tended towards more pressor use and less fluid use. And maybe there's a little bit of a risk of harm, particularly renal harm there.
I think you're absolutely right. And that oftentimes happens in medicine, is that we identify a problem and we're not necessarily thinking comprehensively about what the action is to treat that problem. Then we swing over to the other side and we find out, well, maybe this isn't quite exactly how we should be doing it. And let's recorrect back and hopefully we will find that sweet spot.
We've got a real weakness, I think. If a little bit of something's good, a lot of it must be better.
That's right.
So that's like, if giving less fluid is good, giving no fluid must be brilliant.
That's right.
Which clearly has its adverse consequences from time to time.
It is interesting to reflect about why patients have vasomotor failure and require vasoconstrictors during anesthesia. It's not entirely the result of anesthetic drugs. There are lots of other factors at play, like systemic inflammation. And the use of vasopressors is not addressing the cause of that problem. And in fact, it's not even that easy to make that diagnosis. It's sort of a diagnosis of exclusion, isn't it, Mike?
It is. And there's lots of talk, but I don't think any widely adopted interventions. The inflammatory consequences of surgery and everything else that's going on are clearly significant and we can measure them, but there seems to be very little data that modulating them helps. And we know from the critical care literature that you can really get that wrong. We struggle to find inflammatory modulators that help, and we seem to be quite good at finding ones that will cause harm.
Yeah, indeed.
I think I would add that's another gap that I think we need future research. As you know, a lot of particularly our mature adults or the people that are over 65 walk around with a chronic state of what's called inflammaging. And so they come in with an inflammatory state, like you said. And the stress of the surgery procedure is another inflammatory hit. And the stress of hypotension would be another inflammatory. And so it's hard to step back and say, well, I need to fix the inflammation, and so I'm going to ignore that hypotension because you need to fix that third hit to a patient.
So moving forward to what you brought up earlier about monitoring after the patients leave the PACU, what did the group decide we should be doing about that?
Well, the ideal state would be to have a continuous blood pressure monitoring throughout the perioperative period, whatever that is. Some patients go home. There are wearables now where you could actually do that, but I think that's far off. If you do go to the floor, then it's some sort of continuous or more frequent monitoring of blood pressure to detect the deteriorating patient was our recommendation. And then some patients go to the ICU where they're closely monitored, often with intra-arterial lines.
Did you discuss the types of technology available to do that? Also the systems, the response systems?
We discussed those in some detail, and the lead author, Mike Scott, has a great system, kind of a station where you would have a system that would have physiological variables inputted, and then you would have somebody there, a healthcare professional, that would intervene frequently.
It'd be like this sort of Apollo Space Station Command Center. We'd have headsets like this and a bunch of monitors to look at. It'd be an interesting job seeing the patterns of hypotension in the patients. You'd need to do it 24 hours a day.
In the future, that may be supplemented by artificial intelligence, where you wouldn't need to necessarily have a human there looking at all 200 patients you're monitoring. The artificial intelligence would pick out patient 47. Something's going on here. We need to get a human to look at that and make an intervention. So the future is very bright with advancing technology.
If you look at post-operative critical care, particularly the advanced recovery care units, high dependency units, interventions to manage blood pressure seem to be the dominant type of intervention. Probably more than half of everything that's going on is all about what we're talking about. And whilst we're probably quite good at triaging patients to those sort of units, it does imply there's a lot of things not happening on the ward because we're infrequently measuring blood pressure as opposed to continuously monitoring it.
And of course, the day when this sort of technology will be transported to middle and lower income countries seems rather far off, unfortunately.
I think you're right. There are some challenges even with the high-income countries now with really getting the technology that's already there to be available and fundable within healthcare systems. But until we get it in the high-income countries, then that can trickle down into middle and lower-income countries. It'd be nice to snap your fingers and have everything perfect, but one step at a time.
Absolutely.
I couldn't agree more. Now we seem quite challenged financially for a variety of reasons. But if you can formulate a business case whereby the cost of the intervention is exceeded by the benefits from reducing the harms, if we're doing the right thing, one would expect that the patients could stay in hospital less long, have less adverse consequences subsequently, and align all their incentives right. Maybe these devices will pay for themselves.
I think there is very little question, at least in my mind, that will work on a national level, because there is indeed less harm. The financial incentives at the very local level may be misaligned, so to speak.
The paper was the most read or downloaded paper for the year in anesthesia and analgesia, which is amazing and wonderful. Were you surprised? And what do you think the reason for that was?
Well, I was a little surprised. I knew that this came out. It was a big need within anesthesiology and perioperative medicine, and it was a very esteemed group of experts that came and resulted in this. The paper was high quality, and I knew that it would be highly viewed, but to be actually the most viewed was a very, very pleasant surprise. And I think it tells you a little bit about the interest and the knowledge about this as a major healthcare issue within perioperative medicine and the need to develop new fixes for it.
And what's next for the APSF?
Oh, we've got a lot of things going on. We have a yearly Stolting conference that last year was on medication errors, this year obstetric safety, and we also are having a technology conference that will be a satellite conference of the World Conference in Marrakesh on emerging technology. So we've got a lot of things going on. In the area of hypertension, we continue to work to do our part with a public campaign for awareness, but there's a lot of other parts out there that are working on this, so people will become more aware.
Can I ask a question I've been dying to ask for, you've never got around to asking you, Dan? Who was Stolting?
Robert Stolting was the second president of the Anesthesia Patient Safety Foundation. He was chair of Indiana University for quite a long time, one of the icons in the specialty, and he retired from being the president of Anesthesia Patient Safety Foundation probably about 8 years ago. And so this Stolting conference, which has been a consensus conference of the Anesthesia Patient Safety Foundation for about 25 years, was named after him.
Thank you so much for joining us and taking time out of your busy schedule at the conference and possibly some relaxation time on the Waikiki Beach. It's been lovely to talk to you, Dan.
Thank you for this opportunity. It's a pleasure to talk about this issue.
We wouldn't be here without our sponsors, BD, formerly Edwards Life Sciences, and also GE Healthcare. Without their help, we wouldn't be able to bring Top Med Talk live and open access to the world as we're able to do. So we're very grateful for their support. Look forward to seeing you on our next podcast, Mike.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EPPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.